Hello, this is Nazir Habib from Medical Specialty, and I would like to have a short presentation on the application of non-invasive ventilation and share some ideas and tips regarding the safe use of non-invasive ventilation. Acute use of non-invasive ventilation and the selection criteria for BiPAP or bilevel positive airway pressure is extremely important. Bilevel or BiPAP should be utilized when the patient has respiratory acidosis, either acutely or chronically, where the pH is less than 7.35, associated with increased level of PCO2. In addition, the patient will generally have increased respiration rate or increased work of breathing and abdominal paradox. And so it is important to obtain a blood gas as quickly as one can in patients with severe respiratory distress. There are contraindications to the use of non-invasive ventilation, which obviously includes respiratory arrest or apnea, but any significant altered mental status from drug overdose or CVA or a neurological event should be a contraindication to the use of non-invasive ventilation, as the patient will be unable to protect their airway. Any recent upper airway or gastrointestinal surgery, facial trauma, if the patient is hemodynamically unstable, such as from septic shock or acute myocardial infarction with cardiogenic shock, or if the patient refuses or is uncooperative after some initial attempt at the use of NIV, should be contraindications. The patient's initial settings are generally to dial in inspiratory positive airway pressure, which is a top number, which generally is 8 to 10 centimeters. The lower number delivers EPAP, expiratory positive airway pressure, which is equivalent to CPAP or PEEP. This lower setting is generally used to correct the oxygenation, whereas the upper number, or IPAP, corrects the hypercapnia or increased CO2. The patient's respiration rate may be very rapid, and the tidal volumes may be very erratic, so it is important to allow the patient to accommodate to non-invasive ventilation and assist them with a little bit of morphine or fentanyl to reduce their dyspnea and respiration rate. It is also very, very important to ensure that the patient is in a sitting position, as this will increase their tidal volumes delivered, and especially in patients with obesity or obstructive airway, it is important to elevate the head of the bed to at least 45 to 60 degrees, and this will improve your success rate with non-invasive ventilation very significantly. Initiating the patient on non-invasive ventilation with BiPAP or CPAP, patient selection is key. It is important to get a baseline blood gas and a chest x-ray, select the right mask, initiate some small amount of sedation with morphine. I would recommend 2 to 4 milligrams IV that can be repeated in 15 minutes if the patient has not become comfortable, and then consider Precedex if the patient continues to require some level of sedation. Initially set the IPAP at 8 centimeters, EPAP at 4 centimeters, titrate the IPAP to maintain a tidal volume of 5 to 7 cc's per kilogram ideal body weight. Do not exceed a tidal volume over 9 milliliters per kilogram, as this will risk lung injury, which we know from our ARDS data. Consider Precedex to accommodate the patient and monitor the patient's mental status. There are significant complications associated with non-invasive ventilation, which include air leak. Although the ventilator will accommodate air leaks up to 60 liters, one should allow generally air leaks of 10 to 30 liters. Skin irritation, claustrophobia are significant complications, and one should adjust the mask or the straps, or loosen the straps. For claustrophobia or anxiety, I would recommend, as I mentioned, morphine and Precedex. There is significant risk of mucosal dryness as well as mucus plugging, and therefore please humidify the inspired air with the Fisher-Paykel or some sort of humidification, or alternate BiPAP with high-flow nasal cannula. Any risk of pulmonary barotrauma or pneumothorax will be associated with air trapping rapid respiration rate, and as I mentioned, excessive tidal volumes, which should be maintained less than 9 cc's per kilogram. In summary, non-invasive ventilation is most useful in COPD with hypercapnia. This is a level 1 recommendation based on randomized controlled trials. Also consider CHF or pulmonary edema, where the patient may not have respiratory acidosis. One should use CPAP 8 to 10 centimeters while the patient is being diuresed. Community-acquired pneumonia, especially if the patient has excessive secretions, may be somewhat risky. Therefore, high-flow nasal cannula might be preferable. Patients with obesity, hyperventilation, and hypercapnic encephalopathy will definitely benefit from non-invasive ventilation and increase the BiPAP and PEEP as tolerated. One should avoid non-invasive ventilation in the patient with acute myocardial infarction, septic shock, altered mental status, excessive secretions, and multiple organ failure. Intubate the patient or consider high-flow nasal cannula as an alternative. There are further details available on our website and further presentations, so please visit our website for other presentations on respiratory care and critical care. Thank you very much for your time.